in healthcare delivery in Malaysia. So the contents for today is as shown. So I'll be starting off the presentation for today with introduction. It is a short review of the current situation about health inequity is with the advancement in technology and economic growth, there is enormous health improvement in health services, and also this causes an increase in the well-being of people globally. So one of the evidence to support this statement is the life expectancy at birth increases from 46.5 years in 1950s to 1955 to 68 years in 2009. But in spite of the constructive outcome in many countries, the presence of health inequity is undeniable at some parts of the world. So what are some of the health inequities or inequalities that are occurring in the health sector? One, we can access it in respect to the health determinants. Secondly, it is due to the access to the resources needed to improve and maintain the health. And thirdly is also the health outcomes. One of the there are many evidences available in regards to health inequities, but some that I've picked up is one, we can look at Africa. Africa is most severely affected region for HIV epidemic, with 22.5 million of them are HIV infected people. This accounts for two-thirds of the affected people across the globe. While we can see that 36 million deaths due to non-communicable diseases are occurring more frequently at the low and middle-income countries as opposed to the developed countries. So what are the factors that are contributing to their health inequities? First is health services. Health services, one of the major problems that they are facing is a limited resources. And secondly is the skill deficits, because the demand is more than the supply, therefore we are lack of the skilled people to provide the adequate health services. And thirdly, it's due to also an increasing burden of the emerging health problems as well as the aging population, as not only the developed country, but now the developing countries are also moving towards the phase of having more aging populations as compared to the productive group. And fourthly is most of the public expectation in terms of the health services are not met in many regions due to again limited resources as well as the deficits in the skilled attendants and personnel. So when we narrow it down to Malaysia, Malaysia is well known across the world that we have an established public healthcare system that provides the universal coverage of healthcare, and the financing is mainly through taxation. And we have two-tier health system, that we have public sectors as well as the private sectors that are providing the services currently. And the efficiency of the health care system in Malaysia, we are able to measure it through the in one of the indicators that are used to measure it is through the infant mortality. For instance, it has decreased from 75.5 deaths per 1,000 live births in 1957 to 6.7 deaths per 1,000 live births in 2010. But will Malaysia able to sustain equity in healthcare system in the near future? Two factors that we have to mainly consider when addressing this question is, first, the healthcare system is a two-tier system. We have public and private sectors as well as highly subsidized. With an increasing of these topical issues such as escalating healthcare costs, lifestyle-related diseases, increasing number of the elderly in the population, or introduction of new technology, and also increasing consumer expectation, will these eventually will Malaysia able to sustain the equity in the healthcare system in the future is questionable. So to further discuss this, what are the problems we faces and what are the possible solution to address these issues will be discussed later part of this presentation. For now, I will pass on to my colleague to explain some of the common terms and definitions that will be used throughout this presentation now. Thank you.
So before we go on to the main topic of today, there's few terms and definitions that we have to know. First is health equity. Basically, health equity it's absence of avoidable or remediable difference among group of people. Means that they have two types of the health equity: horizontal equity and vertical equity. Horizontal equity means that the equal treatments of equal, no matter what is the class of the income group, low or high or middle income group, or even the social class like the young people or the older people, they all get the equal treatment. For the vertical equity, it means that the treatment is given according to the individual needs. Like the young adult, they have their own needs in terms of the healthcare, and elder people they have their own needs. So they have a different unequal treatments, what we call vertical equity. So next is the health inequality. Basically, health inequality is the differences in the health status and distributions of the health determinants between different groups of people. For example, like the different mobility of the healthcare between the elder people and the younger populations, and it is different with health inequity. Health inequity also is the differences in the health status, but this is preventable. For example, like the unjust, the uneven distributions of the healthcare to a different group of populations, resulting in the health inequity. And next is the health disparity, is the differences in the health status among group of the people. For example, the rich and the poor, they both groups receive different healthcare services. So that's why it causes the health disparities, as well as the social gradient is a state of a health inequity that affects everyone. For example, the poorest get even poor and a worse healthcare status, but the rich will get the better healthcare status, and that is why it causes the social gradient. And next, I pass on to Faisal for the issue. Thank you.
Good afternoon, everyone. We're going to talk about the issues of inequity in health delivery. So the first one is the public-private dichotomy, as what Anthony has just mentioned earlier. There is a big difference between the public and private healthcare delivery in Malaysia. The private health sector has been growing fast and playing an increasing role in the provision of healthcare in Malaysia. Example, there are about 209 private hospitals with about 11,689 beds. And we also have about 22 private maternity homes and 12 private nursing homes. So comparing this with the public health care delivery, we're accounting about 40% of doctors, number of medical practitioners are actually working in private hospitals. So this will cause an inadequate integration between the public and private health sectors, and the private sector mainly caters to those who can pay higher. Not everybody can actually pay for the private healthcare, so most people will go to the public, and this will cause a lot of queue and a lot of services will not be available to them. While the public system provides access to everyone, but the private one will actually provide only with people that can pay higher. Poorer people have no choice but to rely on government services. There are differences in the range, scope, and quality of services provided at primary, secondary, and tertiary care levels. Example, the private sector provides only the curative services, while the public will provide the primary and the secondary. So steady migration of senior doctors, specialists, and experienced health professionals will move from the public sector to the private health sector. So collaboration with the private health sector in disease reporting and outbreak response has not been very strong and sufficient. The second issue is the human resources. These are not inadequate and it's not well distributed. Most of the experienced specialists will move to the private sector because this will pay higher, and then there will be less doctors in the public health delivery in Malaysia. Example, those who have money will go to the top class, more senior specialists, and this will be in the private. While the poor people, they have no choice, they have to go back to the public sector, and this will cause a lot of problems. The private sector combines an excess supply of some health resources with massive overutilization. So doctors will move from secondary and tertiary care specialists eventually, and then there will be a shortage in the primary care level. Basically, what I'm saying, most of the private doctors will move from to secondary and tertiary, and then the primary healthcare, which is usually for the poorer community at the lowest level, they will have less doctors. So this will cause a problem to the community itself. Third one is the marginalized population health. The first point on this is unequal distribution of healthcare services among the marginalized population. Example, in Orang Asli, there will be less healthcare services compared to other areas in Malaysia. And there is the second one is the disparity in health status among the urban population, such as squatters and the homeless. And also the flying doctor services and mobile health teams, they have irregular visit to village. Example, during the unfavorable weather, both the FDS and the MHT cannot reach these areas. The second one is the immigrant health. Most of the migrant workers, they lack access to medical facilities and healthcare. And there's also discrimination against migrant workers when they seek healthcare at public hospitals and clinics. For example, Malaysians only pay 1 ringgit to see a doctor. For migrant workers, the least they pay is about 50 ringgit. The fifth one is accessibility to services. As I mentioned earlier, the public sector delivery system subsidizes nearly 95% of the patient cost of treatment for nearly 90% of the population in Malaysia. We still don't know if this government can continue doing that, as Anthony said earlier, because of so many issues. So there's a lot of long queues for outpatient services, that, especially during diagnostic procedures like CT scan, examination, treatment modalities like endoscopic surgery, and drugs for chronic disease. This is all a form of inequity. Also, it relates to the doctor population ratio, whereby the population in urban areas like Klang Valley, they have more accessibility to doctors compared to the population in Sabah and Sarawak. Also, the health programs that are provided, they usually provided only to public schools. They're restricted to only public schools. So all the other schools in Malaysia, like the private school, they don't have all these school health programs. The sixth one is variation in healthcare delivery. As I mentioned earlier, the public will take care of only the primary health care, while the private takes care of the secondary and tertiary care. So some primary health centers have certain services available that other health centers do not have. Quality among private hospital or clinics differ. The seventh one is escalation of healthcare costs. There's a demand for new expensive medication and new types of high-cost services. Purchases of this certain prescribed drugs and equipment are not subsidized by the government funds. So these are very, very expensive, and a lot of people, the poor people, cannot pay for that. This will lead to increasing trends of private healthcare. So a lot of people that have money will move from the public health, moving to the private healthcare. And this will include the out-of-pocket payment. The out-of-pocket payment is one of the least efficient and most inequitable means of financing healthcare. This is all from my side. Now Meenakshi will continue talking about the solutions.
So I'm here to discuss on how we should mend this inequity. The possible solution to this would be, first, human resources. There needs to be enough manpower. Human resources, meaning more medical personnel, then medical food, patient food, especially government and private, and good better education, uh, trust in curative care. So there should be a healthy lifestyle campaign. Activities should be culturally diverse. Marketing always innovation
Meenakshi,
Sir?
we can't hear you very well.
Oh, can you hear me now, sir?
Yep.
Okay. So innovation is
Yeah,
important
Meenakshi,
in, sir.
sorry to interrupt. Can you again do it from the beginning? Because we could not follow from the beginning.
Oh, okay.
Is it possible?
Yes, sir.
Yes, you hold it quite close, then we can hear clearly. Yes, it is.
Okay.
Okay, thank you.
Now you can hear me clearly, sir?
Yes.
Okay. All right. So the possible solutions that we might look at, first, human resources. The more number of medical personnel can be included. Quality of medical care should be improved with government and private. And then good incentives should be given to doctors to make them interested in joining as staff in government hospitals. Collaboration with the private sector.
Excuse me, Meenakshi, the
Still no,
sound is
sir?
not clear. Yes, now it is clear actually. Uh, Try to hold the microphone close to your
So
mouth.
it is very close to my mouth, sir.
Now it is clear actually, but later on it is snapping.
I don't
Okay,
know
let's
why.
see then. Might be is the internet speed slow there?
Maybe it's fluctuating, I'm not sure.
Oh, okay. But now we
Meenakshi, can
can
you
hear
try
clear.
it without the headphones? Maybe
Okay.
directly. Maybe it's better.
Okay, wait.
Yeah.
Okay. Can you hear me clearer now?
Yes.
Now
I
it's
can
clear.
hear you.
Yes.
Okay. Right. So collaboration with the private sector, which will help in better surveillance and better
I think
integration.
it's the internet connection. Hold on a second. Internet.
Still breaking?
Yeah, it goes on and off.
Okay. Better integration with alternative medicine in current healthcare system. So this is to be done by integration of the practitioner, better education, setting up both in alternative medicine basically. Then more investment in preventive care. These now can all of you hear me? Hello? Meenakshi, can you hear me?
We
Now
can't
we
hear
can
you.
hear you, but when you
Presenting, we cannot hear.
presenting that time, we cannot hear you. What can I do? I don't know what's happening. It was fine all the while we were testing.
Now it's fine.
Now, yes, now
But when
it's
you
okay.
present it, it goes off. Do you want to change your position? Maybe it's the internet.
I'm sitting as close as possible to the router. I can't get closer than this. Okay. So more investment is necessary in preventive care. A healthy lifestyle campaign. Activities should be culturally diverse and should be part of audiences in different languages. Um, now, innovation in healthcare no, no sample.
I can only hear a fading voice.
What? But how? It was fine. And now I can see
You should sit at this position and present it, I think.
And actually, Ken
seriously?
is suggesting that you
Okay.
can say one sentence, stop, and then say the next one. Maybe it will be better.
And you just
Oh,
sit at this position that you're sitting right now, I think.
okay.
Yeah, right.
Can you hear me now?
Yes.
Okay. Okay. Innovation in healthcare services. Mobile clinics, IT facilities in mobile clinics, and regular drive through pharmacies. Enforcement of better policies. To continue
can't hear you, Meenakshi.
Still? When I say still, I can see it's 5. Oh, man. Okay. Healthcare reformation. To ensure that all Malaysians receive comprehensive, appropriate and quality treatment at affordable prices. This reform addresses the following objectives: to mobilize resources, to enhance efficiency and quality of care, to achieve greater integration in the provision of care between public and private sectors. Can you hear me? Okay. To achieve greater integration in the provision of care. And to better regulate healthcare providers, emphasis on wellness and activities to promote
Excuse me, Meenakshi.
Can you hear me?
Hello? Now we can hear you. Meenakshi, hello?
All this while you couldn't hear anything I said?
Means at the beginning we can hear, but later on your voice just disappearing.
Okay. What about Dr. Ankar and Prof. John and everyone?
Hello. Yes, I can hear now.
So you didn't hear the other parts that I was reading?
No.
What you can do is summarize the thing then. Just a few sentences, you can summarize your presentation.
Okay.
Right.
So,
Yeah.
I think there's a fluctuation.
yes, sir, I think there's a fluctuation. Okay.
You start off clearly and then it just fades off.
Oh. Okay. So Malaysia has what we call the one pair concept, which has been trying to incorporate.
Yeah, there it goes again.
Hmm? Can you hear me, Pranam?
Yeah, when you stop and you restart, it's clear.
Okay.
And when you keep going, then it fades off.
Okay.
I'm not sure how that can be solved.
I don't know. I think it's a fluctuation in the internet. I really can't do much. Okay. So Malaysia came up with the one pair concept, which tries to incorporate all these solutions that I just mentioned. Their targets would be universal coverage, integrated healthcare delivery system, affordable and sustainable healthcare,
Right from
equitable,
I think what we shall try now is those who are not presenting, just switch off the camera. You just go to the top there. There will be an option of the camera thing, right? The video cam, there is an option there. Just switch it off. Yes, then it will be faster, I think. Those who are not presenting.
So targets of one care, universal coverage, integrated healthcare system, effective safety net, affordable and sustainable healthcare, responsive healthcare. I think it's going off now. And I'm talking as loudly as possible. Client satisfaction, personalized care.
No, we can't hear you.
Okay, hold on. Can you hear me now, sir?
Yeah, I can hear you.
Okay. Hospital services, autonomous hospital management, patients referred by primary care professionals, then financing through field-based judgment, then reopen budgets for public hospitals. I don't think anyone can hear me.
Yes, the next presenter.
Who's presenting?
It's Puvi.
Oh, okay.
I don't think she knows. Puvi, you need to start now. Yes. Unmute yourself and your. We can't hear you, Puvi, because you have it mute.
She has to.
Yeah, you have
Yes,
it mute.
she has to unmute.
You have to unmute. I don't think she can hear us. You need to unmute yourself.
Purvi, you need to unmute. The sound is in mute mode. Can you hear me?
She's having some technical problem. Just a minute.
Okay, okay,
Yeah, just
okay.
a minute. Thank you.
Something technical problems are coming.
But I can hear her. I can see her moving, but I can't. I can see her picture moving. No, we can't unmute for her.
This one, how to unmute? It's not coming here.
Dr. Anko, I think you can unmute her, right?
Hi. Actually, I cannot unmute. I can only
Yeah.
mute her. So unmuting is from her side. She has to open it up.
Okay, maybe she should go off and then join again.
Uh, okay, might be. Then I'll send the invitation once more.
Yeah,
Just
we
a
should.
second. Yes.
Puvi, can you hear us?
Okay. Okay, then put her back.
Okay, she's off.
I will put her back once more. Yes, I have invited her now. Let's see.
Okay.
In the meanwhile, we can actually have some discussion, the portion which we have already presented.
Okay.
Yes. These things are coming from where? What we need to do is in front of every presentation, you can put a disclaimer statement, which I have just put in the our. I will again put it once more. Similar to that line, you just put it there. Copy.
Anko,
Yes, sir.
uh, can you just check? I think Purvi is having a problem linking.
I have already sent the invitation once more. So I
It's
think
not.
there is an internet problem there.
So when you say that, I mean, when she tries accepting the invitation, can you hear me?
Dr. Ankur,
Yes.
Purvi she's having a problem stating that whenever she wants to accept the invitation, right? The
Huh.
message indicates that she's not allowed to join this group.
Join the call.
Yeah.
Why she's not allowed to join the group? So I am just 1, 2, 3, 4, 5, 6, 7 are there, right?
Yeah.
9. Okay, then I will request Dr. Pran to step out for a while. Let me see if I can put her back now. Jani. Now I have resent the invitation once more. any one of you try to invite her separately to join this conversation, if that works.
We will try.
Yes.
Dr. Ankur, hello.
Oh, hello. Yes.
Yes,
Tell me.
we are unable to invite her and she also unable to join the video call.
Okay, then once more I'll try. Let me see. I think that is an internet problem there. If the internet is slow,
Mm-hmm.
they might not be able to accept our invitation. That could be the thing.
Okay, let me ask her.
Uh, I'll send the invitation once more.
Tanko,
Yes.
I told Apuvi to restart her computer. Maybe there was a problem.
Okay, then in the meanwhile, we start the discussion, whatever is presented so far, right?
Okay.
So you can ask each other questions first. Then I'll invite Prof. John to ask some questions.
Dan, why did you change these slides?
Do I have to show the slides again?
In case of any clarification.
Yeah, I'll show it.
Anko,
Yes, sir.
what I would suggest is for this session, keep going as long as you possibly can, and
Okay.
make a note of all the technical issues that you're facing.
Okay.
At least, let's see how these can be resolved.
Yes, actually,
I
Mr.
think,
Hasnain is with me now. He is
yes, that's
also
right.
observing the challenges which we are
Yes,
facing.
right.
Yes.
Yes, I
So,
think when it comes to the presentation of the slides, we can see the slides clearly. It is fluctuation in the case of Meenakshi. Uh, we had that challenge where her voice was fading. In the case of Faiza, it was not a problem, I think, and Antri as well. Uh, I think the 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 flow of the fluctuation in voice, where in the case of Meenakshi, is probably the line that she is using. I'm not sure where the problem is, but it's external to IMU, I think, because everybody at the same time realized her voice was going down.
Yes.
So it might be just a few issues that we might have to deal with. So, yeah, give it a try
Yes.
and see whether any new things crop up.
Okay. So right now I'll
Okay.
tell them to occupy the time by discussion till Purvi can join us. I have again sent
Yeah.
the invitation.
Right.
So let's
Yeah.
see. Yes.
Okay.
Okay. So one of you again try to send the invitation to Purvi if she can join in. Right? I will again send her the invitation from my side.
Okay, Dr. Ankur.
Yes, so if possible, Teng show the slide here, share the screen with us, and then start the discussion.
Hello. So I just show the slide.
Yes, please.
Okay. Where should we start from?
You can keep the slide from the beginning and let's see who is asking which portion. Then accordingly you can take us to that slide. Right?
Okay. So I just go through one slide by one slide, then just stop me whenever you have questions, right?
Okay.
Okay.
Slow down.
Okay.
Go back to the previous slide.
This slide.
Okay. No, the next one.
Next one.
Go forward. One slide. Yeah, stop. No?
This slide.
Yes.
Okay.
I had a problem with this term you're using, has two-tier health system. And I know that from your presentation is dealing with public and private. But my problem is this, that in the healthcare delivery system in Malaysia, when we use the term two-tier health system, it refers to the system of the health centers and the where a doctor is based, serving 100,000 population as one level, which is the higher level, and a lower level, which is the where the rural health nurse is based. What do they call that? Clinic desa.
Ah.
Community
All right.
clinic.
Yes, community health clinic. So yeah,
There's a
we
question.
could refer. Yeah, we could refer this as being that two-tier. Well, I'm not sure how whether there's a terminology to capture public and private dichotomy.
Ah. So
Has a maybe it could be has a dichotomous health system.
dichotomous.
Yes,
You
sir, I
follow
think
me?
you can use dichotomous.
Yeah,
Yes, sir.
because I heard that word later.
Ah,
so that there's no confusion between what I mentioned a little earlier about the health center and the community clinic being the two-tier system, which is the accepted norm in Malaysia.
So instead of saying has two-tier health system, we can say has dichotomous system.
Yeah, has a dichotomous health system, a public and private.
Okay.
Okay?
Okay.
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 I'll go to the next.
Yeah. All right.
Yeah, the
Proceed.
same thing.
So same here,
Yeah, the two tiers.
number one.
Yeah.
Okay, guys.
Yeah.
Let's discuss about this. I have one question here.
Okay.
So currently, the Malaysia has the dichotomous health system where we have public and private, right?
Yes.
Right.
Okay, because the public sector, the public hospitals and the services are highly subsidized by government.
Mm-hmm.
Okay, in the near future, what is your opinion that if the burden of the public sector continues to rise because
Mm-hmm.
people prefers it more than the private,
Mm-hmm.
will this lead to health inequity or there might be some other factors that could lead to inequity?
I think that. Can you hear me? Hello.
Yes, we can.
Oh, okay. So I think that if the burden on the public sector rises, then there will definitely be health inequity. There has to be a trade between the public and the private sector. Because that is one of the main issues because we don't share the burden. Right? We don't have any-
We can't hear you now.
Yeah. Can you hear me now?
Yes.
The burden needs to be shared. I can say it shortly because you can hear it only like that much.
Okay, in that case, right, the One Malaysia concept that they are proposing, the One Health Insurance Scheme,
Yeah.
do you think it is feasible to carry it out in Malaysia?
If the burden increases, no, it won't be feasible.
It is not feasible.
Sorry, I'm keeping it short and sweet.
It's okay.
All right. I go with the next slide.
Sure.
Dichotomy. Is there any question?
Excuse me, guys.
Yeah.
Is one care concept the same as the one care Malaysia they're
Yeah.
talking about?
Yeah, it's the idea behind it.
Yep.
Oh, okay.
I've got one question. I saw the slide just now talk about the healthcare services to the immigrant.
Mm-hmm.
The charge will be different, right? So it will cause a health inequity. What do you guys think about that?
What? I'm sorry, I didn't get it. What?
Do you agree with the things like they charge more on the immigrants than the local? Or you think that it should be health equity among all because of the humans' right?
Yeah,
Yeah, there
I
should
think
be health equity.
go ahead, go ahead.
Sorry. No, it's okay. Go on, further.
Okay, I'm just gonna say, especially for the migrant workers, I think they should treat them the same as, you know, the way they treat the Malaysians, if to be highly subsidized too. I mean, I can understand for the, for the foreigners, they need insurance and all that, but for the migrant workers, I think it should be the same.
If not the same, at least say they charge 3 ringgit for the Malaysian, they should probably charge say 5 to 7 ringgit for the immigrant.
Now they charge 1 ringgit, and
Yeah,
then
and I'm
they
just
start
saying there must
charging
be like a
people.
margin is different. That's all.
But if we equally charge on them, right, it will cost more foreigner to come over to actually utilize our healthcare system. This will cost like even more cost to the healthcare system, right?
See, that is why there needs to be a sharing between the private and the public sector. And apart from that, completely putting the burden on the government also is not the wise idea, I think.
I can't hear you.
Huh?
Yeah, we're back now.
What has happened?
I don't know.
Everyone
Um,
disappeared from my screen and then it just started.
Yes, but we are still connected, I think, right?
Sir?
We are
yes, we're
still
connected
connected,
now.
I think. Yes.
Yeah.
Only Purvi, I have repeatedly sent the invitation. It's still not going. Let's
Yeah,
see.
another question I have on the inequity. How about the other services, like the other services in the hospital? Are they subsidized too, or it's only the consultation?
No, everything is
Others is
subsidized for Malaysians.
yeah,
So you mean when you
Everything.
pay one ringgit, you get everything free?
it's not like everything. Maybe it's just for the outpatient care, but for the
So how
inpatients,
about
will
if it's inpatient? How
Okay,
about if it's
okay. See, if they are admitted for like 5 days, right, they end up paying about 50 ringgit at the most.
30 ringgit? So how do
50.
they calculate this?
It's a 97% subsidization or something like that.
So everything, all the services will just be 95% of it will be subsidized. So you
Yes.
just pay like 5% of it.
Yes. As
Oh.
Malaysians, that's the advantage that they have.
Yeah.
Dr. Ankur,
Yes, tell me.
yeah, Purvi says she unable to continue further due to some error. She unable to join into this conversation at the moment.
Okay.
Yeah.
What we do is any other questions you have at the moment?
No, we
No.
don't have.
Okay, so the only thing you can do is those who are from different countries, right? Try to see what are the inequalities in healthcare in your own country which you can perceive. and see how much you can compare it with the problem in Malaysia, just now that we discussed, right? So this is the only thing you can do on your own. And
Okay.
yes, that is a thing. Suppose say we ask some kind of a question like this in your exam, then you put that perspective also there, what you have actually experienced in your own country, right?
Okay. Okay, sir.
Yes, sure.
Otherwise, the discussion was very enthusiastic and very informative. And just like one disclaimer statement we'll put at the beginning of the slideshow before you submit it. You can submit it online to our portal next to the seminar topic in our MSCPH medical sociology module. You can there is an assignment created, so you can upload the presentation there. All right.
Okay.
Yes.
You
So
wanted
the
to
slide.
insert this disclaimer and put it on online as a no?
Yes, actually, that will be the second slide in your presentation. Just put it there and then upload it on the portal, right? Since
Okay.
if you have done it together, so the same slide you can put it next to your
Okay, so you want each
assignment.
of us to upload it, is it?
Yes, I think so because this thing, the assignment is created in individual name. That's the thing.
Oh,
All
okay,
right,
sir.
so I'll be evaluating your presentation based on that, and the Purvi's presentation I'll organize it some other time when she's having internet connection. So it's not a problem. Now what we can do is we can quickly take a break of 15 minutes and again join back at 4 o'clock to have another presentation.
But Dr.
Uh,
Ankur,
Yes.
will
Purvi is not
we?
available
Yeah.
for to
Maybe
What
we
is
try
it?
to off and then we try to connect again after this 15 minutes later.
but just a moment, I will ask her and see.
Otherwise, you can request her to come to IMU. She is staying nearby, right? If possible. Or
Yeah.
those who are not having, like Meenakshi is having some problem with the sound, right? So you try to move to some other room and see if you can get a better connection there. That's the only thing we can try.
So at
Anyway,
4 we are
in
going to
case
have another presentation.
in case she cannot present it now, Purvi, I will take her presentation later. But the things are ready, right? The slide presentation is ready, so any one of you can take charge and present her on her behalf. It's not a problem, right?
Okay, sir.
Yes. So, what will be the next topic?
Migrants. The same migrants.
Problems of the
Migrant.
migrant. Okay. Then we catch up around 4 o'clock. Then I'll
Okay.
send one more invitation. Yes.
Okay, sir.
Okay then.
Okay.
Thank you very much for
Anko,
the
I
nice
may step
presentation.
out.
Yes. Sir. Okay, sir. This thing
Yeah.
I will record the thing and later on I'll show you.
Yes.
We are recording the thing
Okay.
and then right now we won't publish it to the public. We'll
Yeah,
edit the
yeah.
video later on some other time. We'll do it. Before that, I'll show
All
the
right.
final thing.
Surely.
All right. Okay.
Okay,
Thank you
sir.
very much.
Thank you,
All
sir.
right. Thanks to all of you.
Thank you, sir. Bye
Thank
bye.
you. Thank you. Bye.